Welcome to the TGCT Fireside Chat with the Expert. You may hear PVNS and TGCT used interchangeably, and in 2013, they were combined to be the same disease. So during this webinar, all participants will be on a listen-only mode. There will be a question and answer session at the end of the expert's presentation using your questions submitted through the Q&A feature, which you'll find towards the chat. Please remember the information provided in this webinar is not intended as a substitute for your physician's care and guidance. My name is Sydney Stern, and I'm the Director of Giant Cell Tumor Programs, and I'm your moderator for today. We would like to thank our sponsors of today's webinar, Daiichi Sankyo and Deciphera Pharmaceuticals. Thank you all. Now, I would like to introduce our presenters for today, and we'll start with Dr. David Moeller. Dr. Moeller is a clinical professor and the Chief of Musculoskeletal Tumor Services at Stanford and Lucile Packard Children's Hospital. He's an accomplished and internationally recognized orthopedic surgeon specializing in musculoskeletal tumors. And Dr. Moeller has also authored numerous scientific articles in his area of expertise and is a frequent lecturer at medical and military conferences around the world. Second, we'll go to Dr. William Tapp, and Dr. Tapp is the Chief of Sarcoma Medical Oncology Services at Memorial Sloan Kettering Cancer Center in New York. And Dr. Tapp has extensive experience in translational medicine and is currently in charge of clinical basic science and translational aspects of the Sarcoma Medical Oncology Program at MSK. He is also helping to develop a comprehensive adolescent and young adult cancer program at MSK. He has a tremendous interest in global health initiatives and affecting health disparities in underserved areas of the United States and abroad. And lastly, Dr. Nicholas Bernthal. Dr. Bernthal is the Chief of Division of Musculoskeletal Oncology at the UCLA, University of California, Los Angeles, if anyone didn't know. His clinical interests are bone and soft humerus tissue, and he has an NIH-funded laboratory that's pioneering new implant coating techniques and to prevent surgical infections. And so we'll start with Dr. Moeller, and I will share your slides.
All right, thank you. I was asked to review the surgical treatment of pigmented billonodular synovitis. So we can go to the second slide. It's very common for us to disclose if we have any financial interests in the topics we're discussing. I think that's very important to understand the motivation of people who are in an expert situation. This company, Daiichi Sankyo, that is sponsoring this, as far as I can tell. I did participate in a 2-hour expert panel that was internally for them, and I was paid a small amount for that. I have patients that participated in the study that led to the approval of their drug, and that was uncompensated. Stanford was one of the FDA research sites. We currently have a competitor industry group that is doing an FDA trial also in this area, for which I have patients enrolling, but am not compensated. Okay, let's go to the next one. By the way, there were many questions submitted by the audience over the last few days that were aggregated. They are exceptionally insightful questions, and we'll do our best to cover those. So the surgical options can basically be broken down into these different groups and combinations. So arthroscopy is the small incision entry into the knee or whatever the affected joint is. I'm going to concentrate on knees because it's the most commonly involved joint. And most people are familiar with arthroscopy from sports medicines, injuries, and that sort of thing. So arthroscopy is small incisions and introducing a camera through one of the incisions, so you'll be able to see what you're doing inside the joint, and then other instruments that are there to remove things or repair things. This has the advantage of being small incisions, rapid recovery, but has limitations of how much of the joint you can approach. The joint's very complicated in the knee, and to be able to get to all aspects of it can be difficult, except in the hands of the most skilled arthroscopists. And even the best arthroscopists cannot remove 100% of the synovium which is the lining of the joint that produces the fluid to lubricate the joint and to provide nutrition to the cartilage and the other structures inside the knee. This second surgical option is a combination of arthroscopy inside the joint combined at the same setting under the same anesthetic with open surgery to deal with any components of the PBNS that are outside the joint. Every joint has small entry and exit areas where a synovial process inside the joint can get through these tiny openings and expand out into areas that are no longer inside the joint but do communicate with it. So when you have PBNS limited to the joint itself, arthroscopy is an option. When there is disease outside the joint, arthroscopy would have to be combined with open surgery if you were trying to do a maximal reduction of the disease process through surgical means. Now, the next one, open surgery, that would mean you're going to open the entire knee joint up to gain direct visual access, not doing it indirectly like you would with arthroscopy. This involves at least one major incision, very similar to what somebody who is having a knee replacement would have. And if you are a skilled surgeon, you can get to the entire knee joint, including the posterior portions, through this single anterior incision. If you have large masses of disease outside the joint in the back of the knee, then it requires two incisions, the one in the front that opens up and dissects out the whole knee, plus the one in the back. This has, the open surgery has a much harder recovery. It's very similar to if you've had a total knee replacement, requires physical therapy to try to regain as much of your motion as possible. And it's a longer hospital stay in general, 1, 2, or 3 days, depending on the person and how well you do. The fourth option is the same as the third, open surgery, where you dissect the knee apart and remove all of the synovium that you can get to. And then you can add liquid nitrogen or argon beam or another type of application, because even when you think you've removed 100% of the synovium, there are still little bits left. I use the analogy of trying to get rid of crabgrass in your lawn. You can pull it all out, but there's going to be little tiny bits of root left and maybe some seeds where it will likely grow back. I myself trained at Memorial Sloan Kettering, which was the foundation of cryosurgery in musculoskeletal tumor. And I learned from the masters there, and I prefer liquid nitrogen, which freezes things to death, but keeps the proteins and the other structures to where they remain viable if you do it correctly. Argon beam is a heated ionized gas, so you're basically putting a little flamethrower into the area, and that will char and destroy the proteins and other things that liquid nitrogen tends to preserve. So my own preference is cryosurgery. I like cold over heat, but that's an individual preference. If you choose to use an adjuvant, the surgeons will use the ones that they're most familiar with and think are most effective. All right, well, I'll go quickly through these others. So these next are intraoperative photos that are going to follow here. So anybody that's a little bit squeamish may want to look away until I finish this. So PBNS comes in a focal form and a diffuse form. The focal form is a single nodule or sometimes 2 or 3 nodules that are separate, and the remaining synovial lining is normal. Under these circumstances, the correct surgical removal is either through arthroscopy or through a small open incision, just enough to remove the nodule. The outcomes between the small open and arthroscopic are probably equivalent. There are some of us that believe cutting these out piecemeal and chopping them up inside the knee might release some cells that would implant elsewhere. So my preference is generally a small open incision to remove this rather than the arthroscopic. Neither one is right, neither one is wrong. So it's personal preference of the surgeon and personal preference of the patient. Okay, next one. So this is a good illustration of an MRI on the left side of the diffuse type. This is where the entire synovium is involved. What's normally a very smooth surface, like a putting green, becomes a seaweed forest, like a kelp forest off of California. The MRI on your left is from the side of the knee. The kneecap is in the front. The white material in there is actually the fluid component. Normally, there's only a half an ounce or so of lubricating fluid in the joint. When you get PVNS, a lot more fluid is produced, and that is what results in the majority of the swelling. You can also see the dark, small areas in the white and in the front of the knee there, that are these fronds of kelp-like projections that you're seeing in the photo to the right. In the back of the knee, you can see there's a large white area with two kind of dark parts in it. This is actually outside the knee joint. And so this is where arthroscopy alone would not be capable of getting to that area. So a second procedure is done to go in the back of the knee. These, and this is a good representation. A and B are these synovial fronds, and they wave around with the fluid going through the knee. And these are what the arthroscopist has to cut out using a suction cutting device or ablate them with a radiofrequency ablator that basically tries to heat the synovium and kill it. Down below, you see after all this material is removed, you can actually see the nice white cartilage. That's the articular cartilage that you see when you pull a chicken leg off, that nice white cartilage at the end. This is finally revealed once you've removed all of that synovitis. And that's a masterful resection there where everything looks pretty normal once the arthroscopist has done his part. Now to the right side, after the arthroscopy, the patient's turned over. And if you have to go in to take things out of the back of the knee is like a pipe chase in a building with all the blood vessels and nerves passing through it. So it's a relatively higher risk area. The incision's much more open. You see here on the left side, those are the top of the calf muscles. The little stringy things going into the calf muscles are the nerves that innervate it. And then the blue thing below the nerves is the popliteal artery and vein. That's the blood supply to the lower leg and foot. If you operate in the back of the knee, the first time, things are very well defined, and it's possible to easily identify each structure and protect it while you're removing the lesions in the back of the knee. The second time you come in, there's a lot more scar tissue and things are not nearly as visible. And so there's very little risk on the first surgery, but subsequent surgeries carry a higher risk of some nerve or blood vessel damage. This is an indicator of an open synovectomy. The patient's hip is to your left and his foot is to the right. All of this dark brown material you see is what the synovectomy, the synovium looks like in PVNS. The white area right in the middle is part of the cartilage, the articular cartilage on the tibia. And the kneecap is actually pulled up under that retractor that you can see to the upper part of this picture. So this is a much more invasive procedure, but it does give you the advantage of being able to see every part of it and apply your adjuvant cryosurgery or argon beam or other method.
Thank you, Dr. Muller. Dr. Tapp, if you want to try and share your screen.
Sure will. Let's see what we can do. Okay, let me know if you can see that, but actually, let me do this. Okay.
Yes, we can see your
Good
slide.
to see it. Great. So first of all, I want to thank the Life for F group for having us talk about TGCT. And second of all, I'd really, like to acknowledge the fact that the Life for F group is now entering into the patient support realm for TGCT. I think that's exceedingly important. So thank you, Sydney and Sarah. I thought, what I'd like to do is talk a little bit about the disease and then where we're going with potential medical treatments and drug development. Like Dr. Moeller, I too have now some disclosures for TGCT, which to me is a sign that there's a lot of interest from biopharma in developing drugs for TGCT, which is exciting. And that's most of my consultations here is thinking about how to develop drugs for TGCT. I wanted to orient everyone a little bit. I know this is an educated audience, but TGCT is a rare disease. And basically there is a single cell, what we call a neoplastic cell, that's abnormal in that there's parts of two chromosomes together. Chromosomes are what carry our genes that are together, and it's a broken part of the chromosome. And what it does is it puts an on switch next to a gene called colony stimulating factor 1. And what's important about this gene is when that gene is activated, it actually can secrete factors into the blood that will attract inflammatory cells, generally to where this cell is. And so what happens is we tend to see that cell within the synovium, and it's abnormal secreting this factor, and that factor really brings these inflammatory cells to the joint, and it's what causes the tumors that we see. And it's important to know this because the majority of the cells when we see a tumor, like in the pictures you just saw, are not actually the neoplastic clone, they're actually the inflammatory cells. And what many of our treatments do is they try to prevent this growth factor from recruiting those inflammatory cells. So this was some interesting science that happened in the 1990s that really revolutionized our ability to care for patients with TGCT. And as many here know, TGCT, when it's the diffuse type, can be a very disruptive disease. It tends to affect younger people, averaging age in their 40s. And what happens is you really begin to develop these large tumors that can be destructive within a single joint. It's not a disease that we tend to see in multiple joints. And it's not a cancer per se, so it's not something that's going to threaten someone's life, but it can definitely affect the trajectory of someone's life, pain, disability, needing medicines, surgeries, right? So something that can be very disruptive and affect the course of an individual's life. And as Dr. Moeller very nicely demonstrated, there's really two types conceptually that we think about. There's this nodular form, as you can see on the left-hand side, and this is something that's often cured by surgery alone. And so it's not generally the disease that we think about when we actually talk about medicines. We're talking more about the diffuse type. Now, surgery still remains probably the primary treatment for people with the diffuse type, but in the recalcitrant forms where surgery is not an option anymore, or may not allow for significant clinical improvement, it is really a good time now to begin to think about medical management. So it's rare, this component that we're talking about, this diffuse recalcitrant subtype, is actually a rare type, probably only a few hundred people diagnosed in the United States each year with it. And it only represents, maybe about 10% of the total TGCT cases that we talk about. So it's important to understand how your disease is affecting you and what are the options that are available. This is just some pictures. I don't need to go into this, but again, showing the difference of how a nodular localized type on the left is different than that diffuse type, which can really cause a lot of destruction within the knee. And definitely the symptoms that we see. And this was actually a slide that I want to credit not only to Dr. Bernthal, but actually to Daiichi Sankyo in truly trying to understand an individual's course with this disease. And what is known is that this is a disease that can be very difficult to diagnose. It often happens in younger people. Pain, it can take years to diagnose. And often many people in the community, because it's so rare, are not really facile in the disease and understanding it. And so what happens is that many patients, unfortunately, can go through many different doctor's appointments, and a lot of frustration develops before not only a diagnosis is made, but then finding someone who actually understands the disease. And this is really where the orthopedic oncologists come in, and they have for a long time have been the main treatment specialty for TGCT. But even with our orthopedic oncologists, there is a point, especially with the diffuse types of the disease, where, repeat surgeries don't tend to solve the problem as much as it did initially when people are diagnosed. So one of the things we think about is how do we really affect the journey that an individual person who has TGCT is on. And that really came with some of these scientific discoveries, of understanding the biology of the disease, that this is a abnormal cell that secretes a growth factor that recruits these inflammatory cells into the joint. And what was important is that in cancer, we had drugs that actually can target this relationship between the inflammatory cells and the neoplastic clone by kind of blocking the ability of the inflammatory cells to see this growth factor. And one of those drugs was a drug that was used in GIST, which is something that the LifeRF group is very interested in, and also CML, and this is imatinib mesylate. And imatinib mesylate is a weak inhibitor of this CSF1 pathway gene. And there were some nice studies after people were anecdotally placed on imatinib. And this is what we call a retrospective analysis. So looking back at those patients for many sites within Europe and the US. And what it showed is that people actually could have relatively nice responses to imatinib. Now, it wasn't a drug that would magically make things shrink away, but it was something that could really help with symptoms and could affect the trajectory of the disease. So, imatinib mesylate Gleevec is a drug that people with TGCT should consider. Very similar to imatinib is a drug called nilotinib. It's actually the sister drug, the next generation of imatinib that was developed by Novartis many years ago. And there was a nice study that our European colleagues looked at giving nilotinib to patients who actually had tenosynovial giant cell tumor, and they gave patients the drug for a year. And what they showed is that when patients received the drug, there was actually really nice stability within not only the clinical symptoms, but actually in the disease itself. So the disease didn't progress. What they showed is when they stopped the drug, that stability actually was maintained for some time. And we're going to talk about that a little bit. But what was interesting is oncologists were beginning to use the tools that they had, even though these drugs were considered weak CSF1 inhibitors, they were beginning to use these tools to see if they could really help patients. And these drugs actually can have some nice clinical activity. Things started to change, maybe about 5 to 8 years ago when the next generation of the CSF1R inhibitors came out, really stronger inhibitors of this pathway. We were fortunate to begin to work with some of these drugs in early clinical trials. These were cancer clinical trials, phase 1 clinical trials, where we were just trying to understand the drug. But we were able to allow for a handful of people with tenosynovial giant cell tumor to come on study with the drugs. And what we actually found out is that when patients with TGCT received these stronger CSF1R inhibitors, there was actually dramatic responses. Not only were the tumors shrinking, but symptoms were improving. And this was lasting for long periods of time, as long as people were on the drug. But interestingly, in studying a drug and trying to figure out how to develop a drug for a rare disease, there were a lot of questions. Clearly, this was not a disease that fit into our normal cancer pathway. And we had to think about the appropriate ways to actually begin to study the drug. Were we actually determining if the responses we were seeing were meaningful for people? And did we have the right ways to actually measure drug responses? Importantly, and I think this was the biggest thing that happened with the development of these early drugs, is the pharmaceutical companies and the academic communities began to partner with patients to really understand what they went through and really began to ask them, what would be meaningful for you if we had a drug? Is it just decreasing the tumor size? Was it functionality, symptoms, and if so, what? And it was actually this partnering between orthopedic oncologists who understand their experience with the disease, with patients, pharmaceutical companies, health outcome resources to actually develop meaningful metrics so that when we gave a person a drug, to understand if we were helping them. And so we had to develop novel imaging modalities to really understand this diffuse disease and how we could apply that on clinical trials. There were actually some scores to determine whether or not diseases were damaging a joint and would that improve on treatments. And then, as mentioned, there were these patient-reported outcomes, which were important. And this was applied all in a study, which was a large randomized phase 3 study known as the Enliven study, actually looking at pexidartinib. And this was a really important study because it helped to gain the approval of pexidartinib as the first in-class drug for patients with tenosynovial giant cell tumor. So we can actually write a prescription for it now. But it was a complicated study. And one day I'd love to sit down with the audience in the LifeRap group to explain the nuances of designing a study like this in a rare disease that really has a heterogeneous type of presentation in patients, and where we designed good aspects of the study, where there were difficult aspects of the study, where we got lucky. And these are important concepts in developing a trial with a drug that we know has activity in a rare disease. But what was important is it really showed that patients who received a strong CSF1R inhibitor like pexidartinib started to have dramatic responses. And this was measured not only by standard imaging criteria for clinical trials, but also these novel volumetric type measurements. And when you actually look over time, you see these dramatic responses that patients can have. Almost about 70% of the patients on trial had a shrinkage of their tumors of, anywhere from about 30% by certain measurements or higher, or even 50% by this volumetric score or higher. And what was really important is that as we saw this shrinkage and we used the drug, symptoms actually improved and functionality improved, right? So it's not only important to show that disease is shrinking or stable, but it's meaningful for patients. And I think that's what this trial showed, is that using these drugs help people do better over time, right? And that's really the goal, and that's really what's critical. So we now have, these new drugs that we can use for people. But with everything we do in oncology and drug development, it's always, the potential of having side effects. And we know some standard side effects for a drug like pexidartinib. It's something that can cause swelling. It'll turn your hair gray. It can cause some liver inflammation. But what was difficult with pexidartinib is that there was a really rare but very serious side effect where it could cause a what we call a cholestatic process within the liver. It could affect the bile ducts, and in some people this was very dangerous. So, it was a very difficult point in the development of the drug because we had something that was really active and helping people a lot. And we were applying it in a disease that wasn't a cancer per se and weren't threatening people's life, but there was this really, really rare side effect that was dangerous. And this is now really influenced how we use the drug, how we develop the drug. And if you're a patient and want to talk to your doctors about a drug like this, you really have to discuss the pros and cons and the timing of it, right? But what was important is that, having a new drug really transformed the patient's journey, and that the journey didn't have to end with the orthopedic oncologist, but now can bring in a sarcoma medical oncologist to talk about medical options, right? And we have a good amount of medical options now. But really having this team between the orthopedic oncologist as well as a sarcoma medical oncologist becomes really critical, as well as other members of the team, from your primary care doctor to pain doctors to, physical medicine and rehab doctors, right? You really need a big team around you to understand how to treat this disease correctly. Now, the interesting thing is, this was just the beginning. And now we're actually seeing a huge, in my mind, number of drugs come into the field of TGCT. There's now several phase 3 clinical trials with other drugs, which are very good drugs. We're trying to understand their efficacy signals. We're trying to understand how safe they are. There's companies that are making injectables into the knee or another joint that can really work as well, right? So there's a big area now that's developing in drug development, which means for patients with tenosynovial giant cell tumor, I'm really hoping that we're going to have a bunch of options for you. But what's also important, and I think, these are important slides, is we need to understand how best to use these drugs. And the only way to do that is really partner with patients. And I always speak with my patients when we're putting them on a drug that we don't have these types of answers. We're actually working with our patients to understand how best to use the drug. The first questions are, when do we need a drug? And we often speak with our orthopedic oncologists about that. When is surgery still the right first treatment? If we choose a drug, what drug do we use and what are the right doses and schedules? If we start pexidartinib, why not start at a lower dose? Because maybe we wouldn't see any of those toxicities. We don't know once we start a drug how long to continue the drug. And if we stop the drug, will the disease grow or will it remain stable? If we have a nice effect, should we go to surgery? And if we do go to surgery, what do we do afterwards? So these are important questions that our communities need to answer. And when I say communities, it's not only the medical community, but it's also partnering with our patients to do this. And I think, why is this important? Because ultimately, this is your journey, right? We have to understand how best to help you and how these treatments can do that as a component of that journey, right? Just as you may think about surgery or other types of treatment as well. Now, as I mentioned, there's a lot of other drugs that are coming out in clinical trial. I've listed a few here. There's a lot of excitement about the DCC, the Decipher component, macatuzumab, which really was studied early on with pexidartinib and now has been bought by a different company. Max Bio has systemic and even injectable drugs, so a lot of excitement there. We as the academic community have to figure out how to study them correctly. How do we design the trials to actually see what these drugs do and bring them to patients? But again, I think there are going to be opportunities for patients in the very near future, and we need to partner with you and the LifeRaft group to really understand not only how to do this correctly, but also how to make sure that we're understanding how to use these drugs longitudinally as a part of the treatment that a person with TGCT goes to. So I really wanted to just introduce all of that so we can have a nice discussion. And I thought the chat component of this will be the most important thing. So thank you. And I'm looking forward to questions.
And we want to follow up, with Dr. Bernthal, if you want to give your.
My 2 cents. So I hope this is showing okay. Okay. From my end, I have very few slides, and I want to get to the discussion part. As Dr. Tapp and Dr. Muller have suggested, we saw some of the questions that came in, and I think it humbled all three of us that we don't need to give a lot of background here. This is a really well-educated group. I also have disclosures, and I think these were well sussed out. The Daiichi disclosure and the Decipher disclosure are relevant to this. I just want to kind of take a step back, and Dr. Muller gave a beautiful description of the surgery, and Dr. Tapp gave a really nice overview of systemic therapies and where we are and the questions. I think the nice thing about going third in this sort of a talk is to say, okay, how do we bring it back? How do we sort of make it relevant for the patient experience and for our experience to figure out how to help in a disease that's been really frustrating for patients and for physicians for a really long time. So, I think what we've really learned is that we have to move beyond this. And I think 5 years ago, this was it. I would see a patient with the tumor on the left, and it would be, I can just whip it out and it's not a problem. And the tumor on the right is really complicated surgically, this diffuse type, and it's destructive. But we've learned to kind of move beyond the imaging a little bit and really put the patient in the front of this. The function is the key. how symptomatic is this? How much is it inhibiting your life or one's life? Because one of the things we really have to weigh is the side effects of any of these. And people like to talk about side effects. Surgeons like to talk about side effects of surgery, and medical doctors like to talk about side effects of drugs. But everything has side effects and has to be weighed against the risk benefit profile of the other options. And I think observation, quite frankly, we have to know what the risks of doing nothing are. What's the risk of progression of disease, of worsening of the joint over time? We've gotten better at this, and I think we've taught each other across the specialties as far as really learning, some of the things that come very quickly to orthopedic surgeons about range of motion and physical function. But then the medical oncologists are really good at RECIST and understanding side effect profiles of drugs, and the more integrated teams, I think, have really succeeded in teaching one another. I think we've also come to establish this as a longitudinal disease, and really understanding what that means in this space. This is one patient's journey. This is a patient of mine. But you see, I'm not going to belabor it, but this is over a 13-year period. How many surgeries, how many how many life moves, how many days off of work? This has been a massively influencing disease on every decision this young person has made over the course of their lives. And so we need to recognize how the disease impacts life and how our treatment fits into that. This is a recent publication that several of us worked on that I think was really helpful. We sort of just developed a disease registry, and this just got published this year, but we were able to look at 166 patients with diffuse TGCT across Europe and the United States and say, what happens to them? Let's just watch for 2 years and see if they want surgery, they can have surgery. If they want a drug, they can have drug. If they want nothing, we don't influence their decision-making, but how do we get our numbers up so we know what happens down each of these paths? And it's really interesting that half of these patients took a wait and see policy. These are at big tertiary sarcoma centers. And so, I'm not sure anymore that just because we see TGCT in a joint, we need to race in with a treatment. If it's not symptomatic, and many patients have limited progression of their disease. Others have very progressive disease, but understanding the specific biology of one's disease helps us understand it. And so there sometimes is not that same urgency to jump in and do something without understanding what observation would lead. So I end with this same slide that Dr. Tapp showed a couple of times, and I really do think what we're learning is that our understanding of this disease depends on where we are in the patient journey. And what we hope to get to is a situation where, irrespective of what doctor's office you walk into, there can be a sophisticated, thoughtful evaluation of what a patient's options should be across the spectrum. Because I think with a lot of these rare diseases, especially one like this, you can get a very different set of treatment options if you happen to walk into a sports medicine doctor's office versus an orthopedic oncologist versus a radiation oncologist versus a medical oncologist. But what you see depends where you are as a physician. What you see depends where you are on this journey. And explaining the side effects to pexidartinib to a community orthopedic surgeon who usually sees tiny little nodules that they can just remove, it doesn't make sense to them, because why would you do a drug for that patient who you could cure with a 15-minute operation? Much the same as our medical oncologists that only see the most recalcitrant cases that come back and back and back, and the patient's been in and out of the operating room. Talking to them about arthroscopy doesn't make sense. That's already failed most of the time in these patients. So I think we are learning from each other. Most of all, we're learning from the patients. This is a disease. We recognize the spectrum of sort of influence and how much this impacts people's lives. We're trying to hear that and work that into sort of how we develop these nomogram, or these sort of treatment planning algorithms. But the reality is it remains a work in progress. And I love the open-ended questions that Dr. Tapp ended with, I think that's probably where we can kick off the discussion.
Well, thank you all for your wonderful conversations and slides. And so I want to just jump in so we can start getting that discussion going. And so this may be for Dr. Bernthal and Dr. Moeller. Does a joint replacement lower or eliminate your recurrence risk? And could someone be truly too young for this kind of surgery?
There are new total knee replacements that the bone attaches to. We don't cement them, and those can be done at any age. The polyethylene bearings that actually are the non-metal parts, those do have a very slow wear rate. And if we put a knee in somebody who's 20 to 40, we're suspicious that it will require some sort of revision at some point in the patient's life. But these new ones don't loosen generally, and the polyethylene can last 20 to 50 years. So there is no lower age limit, in my opinion. It's built around the patient's needs, the degree of dysfunction they have, and we can reliably predict better functional outcome and less pain after a knee replacement. When I do a knee replacement in PVNS, I do adjuvant cryosurgery on the remaining synovium, trying to do a full, complete synovectomy in the hopes that it doesn't continue to form nodules, and they can even after a knee replacement.
Yeah, I think the only thing I'd add to that, which is a really great answer, I think, both Dr. Moeller and I do knee replacements for high-grade malignancies in kids all the time. And so there's no too young an age. It's about what the risk-benefit ratio is. I think it's really important to take a step back when we see these folks and ask ourselves if the downstream breakdown, if the arthritic change in the joint is the driver of the symptoms, which is often the case in late stage TGCT, or if the tumor is. And there's a very distinct, what we call a phenotype of pain. If somebody has that typical swelling type pain that's not related to activity, but just some days are bad and some days aren't, that's generally tumor pain. If somebody has very mechanical pain when they stand up and put weight on it, that tends to hurt. If they walk long distances, that tends to hurt. Oftentimes that's the arthritic pain. And so the joint replacement part of it is addressing the arthritic pain, which often we need to address. But it's important, as Dr. Moeller points out, that the cryosurgery or the synovectomy is what's taking out whatever your technique is. That's addressing the soft tissue is what addresses the tumor, and the joint replacement is addressing the joint around the tumor.
So we just mentioned about recurrence rate. What do you guys believe the true recurrence rate is for diffuse? Right, you see variable numbers all the time.
I may be biased in this, and I'd be interested to hear Dr. Moeller's number. I think the reality is it's astronomically high. I think, the published rate, if we believe the literature, it's generally reported around 50% for diffuse type in the knee. I think, like in most things, most surgeons believe they are better than the average, and it's a very technical dependent thing. I think the reality is we don't have clear surveillance patterns. And so a lot of people do this surgery and then don't get MRIs ever again if the patient's not hurting. And this goes back to that question before, does a recurrence of tumor, is that a problem, or is it pain from a recurrence of tumor? And so I think that the recurrences are extraordinarily high, but I think there are a lot of people for whom their symptoms are resolved with the surgery.
Yeah, that's a good answer. I don't think it's curable. So I think if you get to 60 or 70, you may be one of the people that becomes asymptomatic, even though you can see residual disease on their MRIs.
Dr. Tapp?
Yeah, I agree. I mean, I think, again, in certain patients, there's a high likelihood this disease is going to come back. I think it also poses the question of how we can use medicines to prevent that, right? And unfortunately, we saw this rare toxicity with pexidartinib, so we didn't feel comfortable delving into these further studies that may have really helped how a medicine could be used as an adjunct to surgery and potentially, could we lower those percentage rates of recurrences? We don't know that yet, although I think people are thinking about how to answer that question, not only with drugs that we have, but also some of the newer drugs that are coming out and may or may not have similar side effect profiles, right? So a lot going on, but figuring out how to use these treatments correctly to support, the wonderful jobs our surgeons do.
That's wonderful answers. So many patients also seem to report that platelets may be increased or changed, or they may be positive on an ANA. Do you think that that is related?
I think it's hard to say, there's such a huge inflammatory component to some of these diseases, right? Remember, it's the recruitment and activation of these inflammatory cells. And I know one of our close colleagues from Milan had a patient that was requiring weekly blood transfusions dealing with the disease because it created such an inflammatory state. And there's something called anemia of chronic disease, where when the body's inflamed, it doesn't have access to the red cells, right? So there's also an acute phase reactant in platelets in inflammatory states where they can go up. So there is a systemic component to this disease that's not well understood, right? And that's really important to speak with your doctors, because that may influence what type of treatments you have. And again, it's not only focused on the joint, right? That's what I think all three of us are trying to say here. We have to understand what the patient is going through, what other doctors or supportive services does the patient need, and how do we help address the big picture, right? And this inflammatory state, how it affects cells like platelets, what it could be doing with other immunomarkers, become a very important feature of all of this.
Thank you. So can TGCT alone be diagnosed with an MRI, or should biopsies always be done?
I think that's a really good question, and I think the answer to that might be changing right now. Quite frankly, I think we went through a phase, certainly in the 90s and maybe early 2000s, where the thought was you needed a tissue diagnosis for sure, and we treated it like most of our sarcomas, where we just need to know exactly for sure that it's TGCT. Then there started to become these echo gradient MRIs that were a little bit more sophisticated, that could pick out the hemosiderin component, which is just very classic for TGCT. So there are some radiologists and or physicians, surgeons who feel comfortable that with modern MRI, it is good enough to diagnose it. I think actually we've had to almost revisit and reverse field now with some of the systemic therapies, because I think the reality is when you're taking a young, otherwise healthy person and putting them on a drug with a side effect profile, we want to be 100% sure, not 95 or 99 or 99.9. And so, I think this gets back to the treatment paradigm to some degree, because if you're a person who is for sure going in to get surgery as your treatment, if it is TGCT, the differential diagnosis there are mostly things that you would also treat with a very similar surgery. Intraoperatively, it wouldn't change what you do, and you're going to obtain tissue there anyway. Excuse me. But if you're going on systemic therapy, it seems to me that you would definitely want a tissue diagnosis.
And the normal tissue diagnosis for this can be done with just a needle biopsy in the clinic under local anesthesia. It takes 5 minutes to do, no side effects except what the lawyers would tell you to talk about. So it's pretty easy and it's pretty accurate. You're just trying to rule out an infection or some other issue that would cause localized single joint synovitis. And that's a small list. And like I said, they're pretty much all treated the same way, surgically.
But by the way, Sydney, Dr. Bernthal and Moeller, they're giving like textbook medical oncology answers here. So it shows the collaboration behind the scenes, right? How we're all thinking about this disease, as one, which I think is great.
Yeah, it's definitely, you could see the collaboration between the different modes of treatment options. And so one mode we are missing, and that was partially intentional, is the radiation. Is there a reason, or do you guys have any comments about where does radiation fall in the treatment spectrum, and should it be used?
All right, so medical radiation to control disease comes in the high dose, like for cancer, and then intermediate to lower doses. All medical ionizing radiation done for treatment purposes carries a small lifetime risk of radiation-induced cancers, which tend to be pretty bad when they happen. So radiation therapy, almost without doubt, can reduce the growth of the PVNS. It can increase the intervals between recurrent surgeries. And in some cases, it can stop the disease from coming back from a symptomatic standpoint. So radiation should be considered. The younger the patient, the less likely it is to be used. The time between radiation exposure and radiation cancers is about 18 to 20 years on average, although I've seen it in as little as 2 years. So that has to be weighed against the lifetime risk, although I believe we'll cure all cancers in 25 years. So you also have to look at it from that standpoint. So if somebody comes to me and says, I want to do everything possible to cure this, it would be, first, I would probably recommend an exposure to one of the medications to see if they're a responder or a non-responder. Then the most complete surgery the patient can accept, followed by radiation therapy in these low to intermediate doses.
I think that's a great answer about radiation. I will just say, because it sounds like our practice is a little bit different, that while philosophically I agree, I think in our group's practice, radiation is not part of, for exactly the same reason that Dr. Moeller pointed out. I mean, it's a risk benefit, but we have stopped using radiation as part of it, and I think that's just a weighing the risk benefit for the patient. But certainly, that's a patient decision.
Exactly. And we rarely use radiation in younger people. When it's somebody in their 60s or their 70s, I have less concern about that.
So I think we have time maybe for one more question, if we keep it short a little bit. And so I will round it up with, so many patients have discussed that they have it affected in their knee versus there's many other locations, but seemingly of the knee. Baker cysts tend to be quite common in conjunction. Do you think that they may cause each other, or that the swelling is involved?
So Baker cysts are caused by a weakening of the capsule of the joint. So, a joint is basically like a balloon filled with water. And as you stretch out one area, you oftentimes create little outpouchings of that fluid, much like you thin out bubble gum and put air into it. And that's how a bubble comes in your chewing gum. And so any process that creates inflammation inside a joint can thin out the joint capsule and can lead to cysts forming. And Baker cysts are just a term for a very specific anatomic location for that sort of an outpouching. But it's any inflammatory process in the knee can lead to Baker cysts form.
Thank you. I guess that was very short and sweet. Thank you very much. So I'm just trying to be conscientious of time. So we may have one more. There was someone who asked about exercise and how does that progress the disease. Do you guys have any comments on use of exercise, and how do you keep staying healthy at the same time?
So the type of exercise you do might cause some of these fronds to get smushed in the joint, and that can cause a little bit of bleeding, which can further activate the synovitis. I encourage people to stay as active as possible and try to live with their disease and work around its limitations, because if and when you have surgery, the more fit you are, the faster your recovery is in general. So I'd like people to do as much as they can with modifications, but recognize that often heavy exercise will lead to a cycle of swelling, which will then take some weeks to return back to normal. And every individual patient just has to sort out what's going to work for them and the degree of stirring things up that's commensurate with their pleasure in life and fitness.
Well, thank you all very much. I want to give enough time for everyone else to get to their meetings and stuff. So thank you, Dr. Bernthal, Dr. Moeller, and Dr. Tapp for your time. And for the patients watching, thank you for coming. And we will have more follow-ups, as there was a ton of questions we didn't get to. And so please send me an email at, I think I'll put it in the chat, and you guys can ask your questions and we can make sure you get your answers. Thank you all for coming.
Sydney, I actually can spend another 10 or 15 minutes. I don't have a hard stop. Do you mind if you and I stay over?
Yeah, we can stay over if you want. Dr. Bernthal and Dr. Tapp, I understand you have other commitments. It looks like someone was in the OR.
Thanks very much.
thanks,
Thanks for
everyone.
setting this up. Bye-bye.
Yeah, thank you. Take care.
For those that want to stay and talk more maybe about surgical specifically, we can go over a little bit. And so one of the main questions we got for surgery based was, is there truly a difference between arthroscopic and open surgeries when it comes to recurrence?
As I said, I think these are going to recur more or less no matter what you do. The question is symptomatic or not. The arthroscopy has a much faster recovery than the full open procedure, but always leaves a little bit, particularly in the back of the knee. It's my belief that full open synovectomy with adjuvants like liquid nitrogen is the single most effective way of trying to maximally eliminate the involved synovium. But it comes at the price of a much harder recovery. And in my patients who have the full open synovectomy and adjuvant, they routinely will lose 3 to 5 degrees of range of motion in both trying to get out to full extension, straighten your knee all the way, and bending. So it comes at a price in both the recovery and some loss of function, but it's probably a little bit more complete from a synovectomy standpoint, and probably gives a little better control for local recurrence. But it's such a marginal improvement, if any, that it doesn't bubble up in the studies as showing one to be clearly superior to the other.
Okay, so then also, if we're talking about maybe outside the knee now, we're talking about a patient who has elbow PVNS that is diffused. How often have you seen elbow? And if you haven't or have seen it a lot, how often does it recur? Do you see that different areas may have different recurrence rates?
So a lot of our upper extremity surgeons who do so much rheumatoid arthritis in the elbow usually will take those cases on. I get them occasionally. I'll often do them in concert with the upper extremity people because they're looking towards a future elbow replacement in many of these patients. So I think the main thing is, if you're going to do as thorough a debridement as you can, you need somebody who's familiar with working around the elbow so that you're not injuring nerves and other things that are critical to forearm and hand function. So those, I think, are best done as a combined with the upper extremity specialist and the orthopedic surgical oncologist, in my experience, at least. The more you're restricted in what you remove because of the critical structures for function and nerve and vessel, the less complete your synovectomy can be. So things like the elbow, the wrist, are going to be much more difficult to control than a big joint that you can open up and really maneuver around and strip away things with a relative freedom that you don't have in the more constrained locations.
That's a great answer. So one of the other questions asked is, sometimes their disease at least comes back after surgery more aggressive than it had been prior to surgery. Have you seen that happen?
Yes, that's rare, but it does occur. I had somebody with almost a football-sized mass in the knee, and it was back in 6 weeks, which we all were concerned we were missing a cancer. So individual patients, you're certainly not all the same. There's subtypes of these diseases that we just don't know that behave differently. And until you poke the bear, you don't know if it's a sleeping bear or a grizzly man-eater. Part of when you have an inflammatory process in your body, it's a competition between the inflammatory component and what your body's doing to contain it. And a lot of these areas, once you stir them up, you release blood and other products that may further inflame the synovium that's left behind, which there always is to some degree in almost every case. So that may be why people will notice that what they have lived with as kind of an interesting companion suddenly becomes very angry after it's disturbed.
So that goes into similar, then instead of doing surgery, can you remove the fluid to prolong some of the symptoms and prolong having surgery?
Fluid in the knee gets produced at a pretty significant rate when the knee is not normal. And so in general, if you just aspirate the fluid as much as you can, and it's hard because those little seaweed things clog up the needle and it makes it hard to get a lot of it out without using a great big needle or some other suction device. And in general, you'll see a reaccumulation of the fluid within days or weeks. So it's not generally done more. If you do it at all, it's done once or twice to just see what happens.
So then what would be the risk of delaying surgery? So if someone doesn't want to drop out of their career or their college, or for whatever reason, they just can't, do the recovery time. So when is the point in which you have to have surgery?
Well, so delaying surgery allows the disease process to continue. And what you want to do is track symptoms. Are people stable or are they getting progressively worse month over month? You may want to do a repeat MRI or X-ray or both to look at, is the disease progressing to where it's getting outside the joint? Are any outside the joint areas getting substantially larger, meaning they're eventually going to start compromising the nerve and the vessel function? So there's nothing wrong with waiting as long as you're aware of your symptoms and are paying attention to what the trend is. And if the trend is worsening month by month, then at some point you're going to want to pick a surgical time to try and turn the clock back. Right? I'm a very conservative surgeon from the standpoint of educate people and then go along with them on the journey they pick as a coach, advisor, and interventionist when needed. So it's perfectly fine to defer surgery, and the possibility of using these medical approaches has made that a much better pathway to experiment with. In general, most of my new patients, I send them to the oncologist first to consider with the risk benefits. Do we want to try that to see if they're one of the ones with a great response or one of the ones with no response at all? And then that gives them some idea of what their future should be. How soon would you choose surgery? If good response, how long do you want to maintain that drug and maintain that response in the hopes of avoiding surgery?
So that makes a lot of sense. So then do you think that surgeons' expertise, a question more about that, how many patients is a lot of patients for someone to see that would make them an expert? Or how do you assess your doctor's capability of making those decisions?
So this is kind of going to be a little bit of a funny reply, but people that are on salary sometimes have different indications for surgery than people that get paid by each operation, whether it's the right thing to do or not. The choice of surgery, yes or no, and if so, what type, is really complicated and involves this multidisciplinary team we've been talking about. So in general, if you're considering surgery with somebody who isn't a musculoskeletal oncologist, it's for the diffuse type as opposed to the focal, it's probably a good idea to get a second opinion at an academic medical center that has some experience with this. Every orthopedic oncologist, surgical oncologist in the country has good experience with PVNS from the standpoint of numbers of cases.
Okay, and so when we start looking more about surgery and someone wants to decide for an arthroscopic or a open surgery, is there the possibility with the knee doing an open surgery versus an arthroscopic to the back, or is the back always done with an open?
So inside the knee joint, there are different compartments that are normally inside the knee. And there's a posterior compartment, and good sports medicine arthroscopists know how to get into that area to remove things or repair things. The disease that gets outside the joint into the back of the knee is not accessible arthroscopically. For an arthroscope, you have to have a cavity or a space in which to put it, to then expand it to be able to see around. The back of the knee has no spaces and has to be done with an open procedure. I see in the chat on the side, somebody said, my surgeon did an open surgery and then realized it was in the back of the knee, outside of the joint. And so that's a case that could have been recognized probably on the MRI. Some of the back of the joint things go all the way down to the ankle. So it's when they run off the end of the MRI, you have to get an MRI that covers the whole thing, because they can follow the calf muscle right down to where the Achilles tendon is, and you need to know that ahead of time. Once you've done the anterior part, even if it's been a big open, there's nothing wrong with going in and doing the posterior part as a second surgery or even at the same time, but it's better to know that ahead of time by good analysis of the MRI. If your MRI is 6 months old, you need a new one before surgery, because this is a dynamic changing process, particularly if your symptoms have increased.
So last one, thank you very much for your time, Dr. Moeller, and staying later. The last question has to do with a tumor being in close proximity to a major vein, especially in the knee. Should a vascular surgeon also be involved?
So a lot of it depends on how comfortable you are operating the back of the knee. Very few orthopedic surgeons ever go there, except by mistake, maybe. And so on the first surgery, the structures are very easily seen and very easily protected because everything is pristine. So I don't, and also most of us orthopedic surgical oncologists know how to do vascular surgery anyway. So if it is somebody that's unfamiliar with the territory, or if it's a second surgery in the back of the knee, having a vascular surgeon available is a good idea. They don't necessarily have to be in the surgery, but they should be immediately available. And at Stanford and most level 1 trauma centers, there's always a vascular surgeon on call that can come in and help if you get into an area that you're past your expertise.
Well, thank you very much. Thank you for your time.
I wanted to address one of the other questions here because it was a gentleman.
Yeah, so you can read it. This patient, he's had 5 bleeds in the 3 months right when he was being diagnosed, and he's in rehab currently. He was asking about the recurrence rate.
Yeah, so our Swedish friend here had a half a knee replacement, meaning they didn't resurface everything, just the part that was most damaged, and was having repetitive bleeds prior to that. The bleeds themselves stir up synovitis, even in the absence of PVNS. Having only half the knee replaced means there's still a lot of the affected synovium present in the knee. So I would consider that you have persistent disease, and then the question is, what kind of symptoms is it going to cause? If you're going to have repeated bleeds, if you are having repeated bleeds despite the half knee replacement, that process is likely to continue until the remaining synovium is dealt with. And even after it's dealt with, you can expect persistent disease, as I've talked about. Now, whether it is symptomatic persistent or not remains to be seen. But the best predictor of future events is past events. So if you've had multiple issues and they continue, they're likely to do so until some additional therapy is applied, whether it be medical, surgical, or other.
Thank you. Thank you for seeing that and catching it. I guess we have, one more question that came in, and since you're here, I figured I'll ask. There's a patient who wanted to know more about obesity and how that may impact, how much weight you carry, and therefore would affect whether the disease is affected by that. So do you see a correlation between obesity and the disease?
So I don't know the answer to that. In general, every extra pound you carry of body weight gets multiplied by 5 across the knee joint because of the leverage involved. So when you drop 10 pounds, you take 50 pounds of pressure off your knee. So in general, lower body weight is associated with all kinds of good health effects, and high body weight, all kinds of bad health effects. In this PVNS, because it's mechanically damaging your knee, if you can probably reduce that damage through weight loss, but it's not going to reverse the damage. It's just going to slow the rate at which damage occurs. There are many patients back, there was a time in early knee replacement at the beginning of my career where patients above a certain body weight weren't offered knee replacements, and until they lost weight. Many of them lost the weight to get the knee replacement and then had their knee pain go away with the lower body weight. So that's always a good avenue for those people that have high body mass index to try exercise and diet and see how things develop.
Well, thank you. Thank you, everyone. Thank you, everyone who stayed and coming. Everyone's a trooper. Thank you.
I just found some more. I just saw the Q&A session. Do you want me to run through this real quickly?
That's okay. I've been running through it at the same time, so I made sure that they coincided.
Okay, great.
Thank you.